Welcome to the Falcon Review's USMLE Step 1 review course of the pathology of collagen vascular diseases. Welcome to the Falcon Review's USMLE Step 1 review course of the pathology of collagen vascular diseases. We will start with a discussion of various types of collagen vascular diseases and then go into a discussion of the various types of vasculitis. I will begin the discussion by saying that collagen vascular diseases are sometimes the most difficult to diagnose and create some reliable guidelines for, so you won't be tested on the abnormal presentations of any of these diseases. You'll get the very classic presentations, and I wouldn't try to belabor the minutia of some of the various different types of variants of these mixed connective tissue diseases and other types of collagen vascular diseases. Instead, try to focus on the high points of the various types of common and testable collagen vascular diseases. So the collagen vascular disorders that are most often seen on board exams as well as in the clinic are systemic lupus erythematosus, discoid lupus erythematosus, and drug-induced lupus erythematosus, as well as Sjogren's syndrome, scleroderma or systemic sclerosis, dermatomyositis and polymyositis, as well as mixed connective tissue disease. Systemic lupus erythematosus is a chronic systemic autoimmune disease where the etiology is not entirely known. We do know that the epidemiology is predominantly female and also has an increased predilection for African Americans over people of European extraction. The common age of presentation is in young to middle-aged women, 20 to 45 years old, and the female-to-male ratio is 9:1. What we see in the presentation of systemic lupus erythematosus is autoantibody production, specifically anti-nuclear antibody, or ANA, which is present in nearly 100% of patients with lupus. On your exam, if you see a patient with a negative ANA, it would be very difficult to say that they're calling an ANA negative lupus on a Step 1 board exam. Though it does occur, it's remarkably rare. Anti-double-stranded DNA is present in 40 to 60% of patients with systemic lupus erythematosus, and the anti-Smith antibody, or anti-SM, is 20 to 30% present in patients with lupus. So the combination of these autoantibodies put together, ANA, anti-double-stranded DNA, and anti-Smith, are considered diagnostic of systemic lupus erythematosus. SLE consists of type 2 and 3 hypersensitivity reactions, so the destruction of cells and the pathology that ensues are both cytotoxic and immune complex mediated. The clinical pathology developed by the American College of Rheumatology in 1997 required 4 or more of the clinical characteristics to be seen to make the diagnosis of systemic lupus erythematosus from a clinical and research point of view. So a malar rash is a butterfly rash on the face in the malar distribution in this area here. A discoid rash is a coin-like lesion on the skin, so an area of uniform inflammation in a circular distribution on the skin. Photosensitivity is also common. There can be oral ulceration, non-erosive arthritis, serositis, particularly pericarditis or pleuritis with pleural effusions. There can also be an associated renal disorder with proteinuria due to lupus nephritis. There is lupus cerebritis, which can cause neurologic disorders, hematologic disorders including but not limited to severe thrombocytopenia, immunologic disorders, susceptibility to infection, as well as anti-nuclear antibody. Remember that these criteria are meant to clarify patients with lupus for research studies, and from the clinical realm, not all patients fulfill these, but we can still say that they do have SLE. The associated conditions with SLE include Liebman-Sachs endocarditis, so sterile vegetations, which are the immune complexes which are deposited on various valves in the heart. You can also get a fibrinous pericarditis because of the inflammation of the pericardium. You can get a fibrinous reaction to that inflammation and get fibrinous pericarditis. Autoimmune hemolytic anemia is not uncommon. Idiopathic thrombocytopenic purpura, so markedly low platelets with associated petechiae. Other autoimmune diseases include thyroiditis, autoimmune hepatitis, diabetes, or gluten sensitivity. The lupus anticoagulant is an autoantibody against phospholipid-associated proteins, specifically beta-glycoprotein 1, and these autoantibodies against phospholipids can lead to a hypercoagulable state, which can be very impressive and lead to both arterial and venous clotting, with associated ischemic changes in the setting of arterial clot. Treatment of lupus, at least systemic lupus erythematosus, involves immunosuppressive agents. The prognosis of lupus is remarkably variable depending upon the extent to which the multiple organ systems are involved. It is a disease with significant chronicity. There are periods of remission and relapse. And the most common cause of death in patients with SLE are infections, and not always from immunosuppressive therapy. The other cause of significant morbidity and mortality in patients with lupus is renal failure. Another interesting component that is worth remembering for your Step 1 exam, you can have a false positive RPR for syphilis due to the autoantibodies interfering with the test. And remember, when seeing a patient with lupus anticoagulant, they will have an elevated PTT, but they are more prone to clot rather than to bleeding. The clinical pathology of lupus nephritis is graded by the World Health Organization in 5 grades. So, World Health Organization grade 1 is normal. You can have mesangial involvement in WHO2. In World Health Organization classification 3, there's a focal proliferative lupus nephritis, which we'll see on a future slide. WHO class 4 is a diffuse proliferative, which is the most aggressive form and requires urgent treatment, as well as class 5, which is a membranous nephritis. This is caused by antibody-antigen complex deposition, which leads to activation of complement and cell-mediated immunity. The characteristics which define lupus nephritis include an active urinary sediment, or red cell, white cell, and other cellular casts, as well as nephrotic range proteinuria. So here's a picture of focal proliferative or class 3 lupus nephritis. You can see a normal glomerulus where between about 1 and 3 o'clock there is that area of focal proliferation, as well as between about 11 to 12 o'clock on the glomerulus, which is pictured. Class 4 lupus nephritis is a much more diffuse proliferative process, and the immunofluorescence micrograph shows anti-IgG throughout the glomerulus. Discoid lupus erythematosus is similar in skin morphology to systemic lupus erythematosus without the systemic symptoms. 5 to 10% of patients with discoid lupus do go on to develop systemic lupus erythematosus, and 35% of these patients are ANA positive, and anti-double-stranded DNA in these patients with discoid lupus is usually negative. This is what the immunofluorescence of skin lesion seen in systemic lupus or discoid lupus is going to look like. There are deposits of immunoglobulin along the dermoepidermal junction. It's worth taking the time to discuss some of the autoantibodies in systemic lupus erythematosus. So the ANA is seen in greater than 95, and one could argue up to 100% of patients with SLE. It's not specific for SLE. It can be seen in many other inflammatory, infectious, or even malignant diseases, and can even be seen in 5 to 15% of normal patients without evidence of systemic lupus erythematosus or any of the other inflammatory or neoplastic conditions. Anti-double-stranded DNA is highly specific for SLE and is seen in 60% of patients with lupus. There is a low titer of anti-double-stranded DNA which can be seen in other inflammatory conditions, and the clinical association of anti-double-stranded DNA is with lupus nephritis. Anti-Smith is highly specific for SLE and is seen in 10 to 30% of patients with SLE. So if you see the combination of double-stranded DNA and anti-Smith both being positive, you can be relatively convinced in the setting of clinical appropriate diagnostic criteria for SLE that that's what the patient in fact has. Drug-induced lupus erythematosus is a lupus-like syndrome in response to some medications that are commonly given. Hydralazine, procainamide, isoniazid, and D-penicillamine are the most common offenders and the most common to remember. So a mnemonic for you is D-HIP. If you have D-penicillamine, hydralazine, isoniazid, and procainamide, it's a reasonable way to remember those particular medications. The unique autoantibody to drug-induced lupus erythematosus is the antihistone antibody. Kidney and brain involvement in drug-induced lupus is uncommon, and the disease usually goes away with withdrawal of the drug. Moving on from lupus to Sjogren's syndrome. Sjogren's syndrome is an autoimmune disease with destruction of lacrimal and salivary glands, leading to an inability to produce tears or saliva. Like all of the collagen vascular diseases, it has an increased predilection for females, and the age is young to middle-aged women. The classical triad of Sjogren's syndrome is dry eyes, dry mouth, with an inflammatory arthritis. And the Miculate syndrome is enlargement of the salivary and lacrimal glands in the setting of Sjogren's syndrome as well. Diagnostic laboratory values for Sjogren's syndrome: you can have a positive ANA with a positive ribonucleoprotein antibody, SSA or Rho, and SSB or La. There is a 40-fold increased risk of lymphoma in patients with Sjogren's syndrome and the associated autoantibodies. It is associated with an HLA subtype of DR3. The Sicca syndrome is dry eyes and mouth, which is a subset of the Sjogren's syndrome, and complications include increased dental caries as well as corneal abrasion. The Schirmer test, pictured on the right of the slide, is a placement of filter paper at the corner of the eye, and you wait for 5 minutes to see if the tear production will produce wetness of that filter paper. The capillary effect of the water on the filter paper should be greater than 5 millimeters at 5 minutes. This is a clinical picture of enlargement of the salivary gland in the Sjogren's syndrome with the Miculate subtype. Scleroderma is another autoimmune disease with a similar clinical profile but different diagnostic criteria. It is an autoimmune disease characterized by fibroblast stimulation and deposition of collagen in the skin as well as in the internal organs. Like all of the other collagen vascular diseases, it has a female predilection of 4-to-1. And again, young to middle-aged women are more susceptible to get scleroderma. The pathogenesis is an activation of fibroblasts by cytokines and platelet-derived growth factor, leading to systemic fibrosis. The diffuse or progressive systemic sclerosis subtype is one subtype of scleroderma, or limited scleroderma, or the CREST syndrome, will be discussed in just a moment. Diffuse scleroderma, or progressive systemic sclerosis, has widespread skin involvement with dysphagia, malabsorption, fibrosis with pulmonary hypertension if the pulmonary vascular tree is involved. There can also be cardiac fibrosis or sclerodermal renal crisis, which leads to rapidly progressive acute renal failure, and these patients can end up on dialysis. The laboratory exam includes an anti-SCL70 or topoisomerase 1 in between 28 to 70% of patients. So this diffuse scleroderma, as the name implies, can involve any organ system really at all. Limited scleroderma, or the CREST syndrome, is typically seen with anti-centromere antibodies and is 80% sensitive for the CREST syndrome when that is seen. And CREST stands for calcinosis, Raynaud syndrome, or discoloration of fingertips when exposure to cold, esophageal dysmotility or esophagitis, sclerodactyly, or telangiectasias. So this is a great picture of sclerodactyly that's seen in scleroderma. It's extensive subcutaneous fibrosis that has virtually immobilized the fingers, and the claw-like flexion deformity is what you can see. This loss of blood supply to the distal extremities as the fibrosis has involved the macro and microvasculature can lead to cutaneous ulcerations and arterial insufficiency ulcers. The mixed connective tissue disease is an autoimmune syndrome with overlapping symptoms of lupus, scleroderma, and polymyositis, and is defined by a positive anti-U1 ribonucleoprotein. Nephropathy in mixed connective tissue disease is rare, and there is much debate in the rheumatologic literature as to whether or not this is a unique entity or is a subtype of some of the other different types of vasculitis or collagen vascular diseases. We'll take a brief break and discuss the various types of vasculitis, so stay tuned for the next section.